We will improve the health of children by improving the health outcomes for every child. And to do that, we'll need to be able to uniquely identify them. My name is Derek Ritz. This three-part video series has been developed for the Asia eHealth Information Network's Regional Enterprise Architecture Council for Health, REACH. Support for this series has been provided by UNICEF, ADB, and WHO. This is video number 2. It looks at how we can begin to address the challenges described in video number 1 by leveraging unique IDs for health and the digital technologies that operationalize them. If you've not viewed it already, video number 1 can be found at www.AeHIN.org. In video 1, we followed the health storyline of a 15-year-old adolescent named Kanya. We learned how ICT investments in collecting aggregate indicators have enabled ministries of health to map their care cascades and identify the sometimes glaring care delivery gaps in their health systems. In its 2015 document, An Agenda for Every Child, UNICEF advocates for an evolution in how we leverage ICT investments to address these care gaps. We need to harness the data revolution to disaggregate our indicators. We need to invest in systems that enable us to track the progress of every individual child. And this leads us to the subject of video number 2. Across multiple databases of person-centric information, how do we uniquely identify Kanya's health story? To be clear, we're actually talking about two distinct but complementary things, and we need them both in order to be able to track Kanya's health story. Thing number 1 is connectivity. There must be a way to connect the separate databases that contain health information. Thing number 2 is identity. There has to be a way to tell which information is about Kanya. Let's relook at Kanya's story from a data management point of view. Information about Kanya's HIV status could be captured, for example, in a web-based application dedicated to HIV care. The community health worker in Kanya's village could use an eHealth application, such as UNICEF's Rapid Pro platform, to capture Kanya's pregnancy status. At the antenatal care clinic and at the birthing facility, they might save Kanya's information in a basic electronic medical record system, or EMR. When he's born, they'll save information about Kanya's baby in the EMR too. And at the immunization clinic, an online immunization registry could be used. We'll explore this particular topic in more depth in video number 3. Connecting care delivery sites to databases is one aspect, but it isn't the whole story. For care continuity, we need these data silos to be connected too. This is done by leveraging digital health infrastructure. A health information exchange, such as the open-source OpenHIE platform, provides coordinated service delivery, two-way information flow, and continuity of person-centric care. Information sharing is the key to consistently delivering high-quality care. It is how they know to put Kanya on a PMTCT protocol, and to also put her baby on antiretroviral medicines, and to take these medicines into account when he's being vaccinated. With digital health infrastructure, we can coordinate our disparate points of service delivery on Kanya's behalf. We can have our health system behave as a system. But hold on, how did we know which information in each database was about Kanya? What about thing number 2? How did we establish Kanya's identity so that we could connect her episodes into her health story? To be able to manage Kanya's health information across our care delivery network, we must first be able to unambiguously identify her. There are 3 factors in establishing identity. The first of the 3 ID factors is biometrics. A biometric identifier is something unique about a person's physiology. This can be something relatively simple to capture and store, like a photo, or something more sophisticated and technically challenging, like a fingerprint or even an iris scan. Even a person's signature is an example of a biometric. It's based on the premise that only Kanya can reliably replicate Kanya's signature. The next ID factor is typically referred to as a wallet ID. Not surprisingly, this is the most prevalent of the three factors. By far the most common something you have is an ID card. This card might include a photo, or it might not. Usefully, low-tech cards can be quite readily and easily issued, including in remote environments. Some countries have even leveraged pre-printed cards onto which the demographic information is handwritten. The demographic data, along with the pre-printed ID number, is copied into a logbook for later data entry. Even a simple, inexpensive card slipped into a plastic sleeve can prove to be surprisingly durable. Of course, more sophisticated cards, including magnetic strips or even RFID chips, can be produced. As is the case with high-tech biometrics, it is sometimes challenging in a low-resource environment to go to scale with these more expensive solutions. Although it is not always the case, the third ID factor is often used in conjunction with the other two. In its simplest form, of course, the something you know could actually be your ID number. However, a common way to use this third factor is to associate a secret passcode or PIN with an ID card. There can also be demographic information that is collected and saved, but which doesn't appear on the card itself, such as birth village or mobile phone number or some other context-appropriate data. A card bearer could then be asked to verify that they know one or more of these other data elements. For Kanya, the act of proving she is who she purports to be is called authentication. Kanya authenticates her identity. As a straightforward case, we might, for example, accept that the woman who has Kanya's ID card is Kanya. To be clear, a number of countries successfully operate their health systems using one-factor authentication based on a simple, inexpensive card. Sometimes, however, there is concern that stronger authentication is needed. A very common deterrent to impersonation is to require two-factor authentication. A person who has Kanya's ID card and who knows Kanya's PIN is probably Kanya. Similarly, a person who has Kanya's picture ID card and who looks like the girl in the picture is probably Kanya. The advantage of two-factor authentication is that it can take simple and expensive ID factors and leverage them together to strongly authenticate an individual. Of course, sufficiently sophisticated biometrics don't require another factor. The person with Kanya's iris is definitely Kanya. So, what is the key to this puzzle? The key is that we need an ID number that we can employ for health purposes that is uniquely associated with Kanya. This ID number should not contain any other information. Its sole purpose is to be different from every other ID number. As a best practice, it will be a meaningless but unique number, an M-bun. Even though there will be a relationship between the two M-buns, Kanya's baby will also need his own unique ID. Everyone needs to have their own unique ID, starting right from birth. As important as they are, the process of establishing unique IDs can be daunting. The Department of the Interior wants to assign IDs so they know who is eligible to vote. The Finance Department wants to assign IDs for tax purposes. People might already have IDs in their passport or on their driving license, or even as part of their formal sector health insurance scheme. A harmonized e-government strategy focused on a single citizen ID is often seen as the desired endgame, but getting there can take years or even decades. There is a case to be made for issuing a simple, durable identifier to be used purely for health purposes. It is a patient safety issue, it is a quality of care issue, and it is an important privacy issue too. Vulnerable populations, such as people who are gay or transgender and sexually active, sex workers, intravenous drug users, these groups face high risks of exposure to disease. They are the ones who most need our health services. These populations often do not feel safe divulging their national ID number. The evidence is that having to do so impedes their care-seeking behavior, especially among adolescents. Video number 3 in this 3-part series describes ways we can leverage ICT investments right away to start more effectively caring for every child. You can find this video and other AeHIN Reach artifacts by visiting www.aehin.org. This video was produced with support from AeHIN's development partners. The content was created by Derek Ritz, Lori Thorell, and Wingxi Chen. Thank you for watching this video.